I'm Dr. Cecil Bennett, and I'm a practicing family physician. And like you, I have struggled over the years with the issue of medication adherence and polypharmacy. With all the technologies available to us today, why are we still using primitive means of subjectively evaluating our patients' medications?
All right, Mr. Newby, you can go ahead and examine your ear. You should just take a deep breath, let it out.
I thought there had to be a better way. There had to be a better way that providers and insurers could capture and evaluate objective data on medication use by our patients on a daily basis. There had to be a better way to reach those patients most in need of aggressively keeping them on track with their medications to prevent hospital admissions, readmissions, heart attack, stroke, blindness, amputation, and other long-term issues due to medication non-adherence. I think I've created a tool that can finally and objectively measure medication adherence that is non-invasive and cost-effective. The tool is called the Bennett Polypharmacy Profile, or the BPP. The BPP utilizes the same LCMS technology used in UDS or urine drug screens with proven sensitivity and specificity of greater than 95%. Let's look at how the BPP can help you in your practice. The Bennett Polypharmacy Profile. What are the current procedures for medication reconciliation that we use every day with our patients? We can refer to a list in the chart or the electronic health record, but many times these lists are incomplete or do not represent medications that other doctors may have prescribed for our patients. I know you've had the situation if you're in primary care where you may refer a patient to cardiology, let's say, and the patient's medications are changed, and when the patient comes back, you don't get a report from the cardiologist, and therefore the cardiologist has one list of medications and you have a different list as a primary care provider. You can ask the patient to write down the medications from memory, but this again is incomplete and depends upon the memory of patients, which is not usually very dependable. You can have the patients bring in their medications and line up the pill bottles, and that's pretty much what we do on an everyday basis, most of us, that our patients come in, with their little brown bag, we take out all the medications and we line up the pill bottles. Unfortunately, some bottles have 5 pills, some have 20 pills, some have 3 pills, and all of them are once-a-day medications. What are some other ways we can do medication reconciliation? Well, with technology, we can get a pharmacy report. But here again, if a patient utilizes different pharmacies, there's a problem. And today, patients will use different pharmacies because of certain prescription programs where they get a better deal by going to pharmacy A for one type of blood pressure medicine and get another deal by going to another pharmacy on their diabetic medications. And it's still a subjective measurement. It only proves that the patient picked up their medicines, doesn't prove that they actually are taking their medications. Now there's a lot of software technology that pulls a lot of data that's available and pulls it into one area where you can see all the medications. Here again is what was prescribed. There's no way of knowing whether or not that list is actually correct what the patient is taking on a daily basis. And bad data in means bad data out. The Bennett Polypharmacy Profile is a unique urinalysis of the most common drugs prescribed by physicians. And again, it's a simple urinalysis that covers the following classes: blood pressure, cholesterol, cardiac medications, over-the-counter pain medications, some herbal supplements, migraine medications, and psychiatric medications or mental health-related medications. This is an example of some of the medications available on the Bennett Polypharmacy Profile. Just look at the headings. Blood pressure, the most common drugs used in blood pressure control today. Diabetes, common drugs used in diabetes. In your bottom right-hand section, the SSRIs and other antidepressants and drugs used in mental health are here as well. And above that, there's some psychiatric and related drugs that are available for evaluation on the BPP. Let's look at some results. Here are actual results of patients that have been screened using the Bennett Polypharmacy Profile. This patient was born in 1938. It's a female patient. The top section shows the patient has taken alprazolam, amlodipine, and several other drugs. Below that, you'll see a green section. In that green section, it tells you what medications the patient is taking that actually is in their system. In this case, the metformin is present, hydrochlorothiazide is present, lisinopril is present. If you look at the first red section, this tells you which medications were prescribed that were negative in the patient's system. In this case, the patient was not taking alprazolam. Now, this could be PRN, so that may not mean a whole lot for alprazolam. But what's alarming is that this patient is negative for glipizide for their blood sugar, they're negative for amlodipine for their blood pressure, and they're negative for their atenolol. This is a patient you would have to bring back into the office and find out exactly what's going on. Was the patient referred to a specialist and their medications were changed? Is the patient non-compliant? But clearly there is some intervention warranted in this patient. Let's look at another patient. In this case, the patient, if you look again in the green section, the only medication this patient is positive for is atorvastatin. But look at something interesting in the first red section. Simvastatin is negative in this patient. And you may say, well, why are there two statins on this reading? Well, if you look in the top column on the medications prescribed, you see that atorvastatin was in the electronic health record. And if you look further down the list after hydrochlorothiazide, you see simvastatin on the list. So what most likely happened here was that different providers were in the EHR. One medication was added and one stopped, and the patient was told that, but it was not adjusted in the electronic health record. So this is an example where the patient is compliant, but the medication in question should not have been in the electronic health record to begin with. It should have been deleted. All right, let's look at another slide. Here's a patient born in 1945, a female patient. In the green section, she's taken her metoprolol, great. But if you look in the first red section, you'll see that she's negative for clopidogrel, which is Plavix, and atorvastatin or her Lipitor. So clearly this is a cardiac patient and she's taking Plavix for a reason and she's non-compliant. So this is a typical patient that you would have to bring back in and find out why is she not taking her Plavix. She may have an issue with atrial fibrillation. She may be status post-stroke. She may be status post-MI. She has some significant issue. That has to be the reason why she was placed on the Plavix to begin with. If she's not taking it, an intervention is definitely warranted in this patient. Okay, let's look at our last result slide. Patient born in 1936. You see the list of medications prescribed at the top. And in this case, there are no medications in the green section. And every medication prescribed for this patient is negative. I would think this warrants an intervention by the primary care physician or their cardiologist as to why the patient is not taking any of these medications. These are just examples, everyday examples, of how the BPP has value in every clinical practice when we're looking at the issue of medication adherence and non-adherence in an objective manner. What would the BPP do? Well, it will eliminate most confusion that patients have about taking their medications. It'll give physicians objective documentations of medications prescribed, and now we can objectively evaluate if our patients are compliant or non-compliant. It will help protect the physician from potential litigation. There are a lot of cases of malpractice that comes down to medication adherence versus not adherence. Here's a tool that providers can use now to verify what they prescribe and to document objectively that the medication was either in the patient's system or not in the patient's system. And of course, it will help to protect the patient from issues of polypharmacy error. When to screen with the BPP? Well, this varies based on the patient. One can screen patients when we screen other blood work, for instance, our A1Cs once a quarter. This is a good time to do a BPP on those patients. And again, it's not just Medicare patients, but any patients you're concerned about with issues of polypharmacy or medication noncompliance who may be taking several medications. BPP can be done during annual examinations as a part of an annual examination, or even on an initial evaluation on an initial visit when a patient first comes to the office. The provider can choose to set up a protocol for the BPP, much like we set up protocols for EKGs or A1Cs. In some offices, it is standing order that if a patient is taking 4 or more medications, that automatically triggers a BPP because there are enough medications that the patient is supposed to be taking that warrants investigation. What's interesting to note is that 80% of screens come back inconsistent with what was prescribed by the provider. And this is over tens of thousands of screens. What are the most common reasons for these inconsistencies? Well, the electronic medical record or electronic health record sometimes is in error. We just looked at a patient previously that where the electronic health record said the patient was taking atorvastatin and simvastatin, obviously an error in the electronic health record, but the BPP was able to objectively show that the patient was positive for the atorvastatin, negative for the simvastatin, which now verified that atorvastatin was the correct medication and the EHR was corrected. Sometimes there are differences because our patients see specialists and the list from the PCP is different from the medication list of the specialist. Routinely, at times, patients run out of their medications, they forget to refill them, they feel fine, and they just let it go, and we're able to help to put them back on track. Many times we see, though, that patients are just confused about what medication to discontinue, so they just take everything that they have, and we all know patients who have done that. Why do physicians sometimes object to the BPP? Some physicians may say, or providers may say, well, I really don't need this test. Well, if you think about it, this is an objective tool. Everything we use now is subjective, lining up pill bottles, getting this report, getting that report, but none of that is as objective as the BPP. And consider the risk versus benefits of drug interactions and litigations if you don't have a BPP in the chart. Some providers say, well, I won't remember to order the test. Well, here again, if you set up a standard protocol in your office of when to order the BPP, just like you set up a protocol for an EKG or a PFT or a hemoglobin A1C, it can be followed by your medical staff. The test can be done and the results then posted in your EHR as you post any other lab result in your EHR. Well, I don't want the patient to pay for this test is something else that may come up, which is a reasonable objection. But fortunately, the BPP is covered by both federal and some insurances. A couple other objectives. Well, I already do urine drug screens. Well, not exactly. The current urine drug screens are really limited to drugs of abuse and used mostly for pain management patients. Those tools will not help you to identify patients taking blood pressure, diabetes, cholesterol, cardiac, and other mental health medications. They just won't. So this test is not in the same arena as a urine drug screen. And finally, some folks say, well, this is just like a genetics test. Well, here again, a genetics test confirms what a patient can take or cannot take. Our screening tool tells you what is in the patient's system right now. Finally, when we're looking at a final objection, well, I've heard that my electronic health record, or electronic medical record, and pharmacy alerts are already checked for this. Well, here again, you know, the reports are only as good as the data that's in the system. We looked at patients who are taking duplicate classes of medications that were in the system, so that data point really doesn't help you as well. The pharmacy can only report interactions of drugs that they know about. If the patient, again, goes to a different pharmacy, there's no way their primary pharmacy is going to know that. And again, patients use multiple pharmacies and over-the-counter pain medications and other over-the-counter medications that the pharmacy may not be aware of. Additional benefits of the BPP. The BPP helps to objectively meet Medicare and commercial insurance reconciliation requirements. So when we're talking about HEDIS or MIPS or any other type of medication reconciliation requirement, the BPP gives you an objective tool to meet those standards and therefore increase the chances of you getting a bonus. So when looking at the different mechanisms of action of different medications you can use, when you're looking at, for instance, the effect of beta blockers, that would affect heart rate by decreasing heart rate and therefore decreasing blood pressure control. I've been an educator or in family medicine for 20 years this year. I enjoy collaborating with my peers on issues that improve the quality of life of my patients. When you're looking at something like diuretics, that's going to affect stroke volume, decreasing stroke volume, decreasing blood pressure. When you're looking at ACE inhibitors or looking at angiotensin receptor blockers, this is going to
decrease total peripheral resistance, and in turn, decrease blood pressure. So you can see for the most common medications that are used for blood pressure control, whether it's beta blockers, diuretics, ACE inhibitors, or angiotensin receptor blockers, that the overall effect is to decrease blood pressure. Well, you're trying not.
I believe the BPP is such a tool that can actually make a tremendous difference in reducing morbidity and mortality in our patients. Well, I've been asked, has the BPP been proven in studies to reduce morbidity and mortality in patients who are non-compliant? And my response is this: just like the blood pressure cuff or a glucose meter, the BPP is just a tool that gives you an objective measurement. It is up to us, the provider, to use that tool to better serve our patients.